Are you recording today? So, good afternoon, good evening, everybody. Today is the second day of the series for social health insurance series. With us today is the CEO, Anthony Lenayara, and our health technical lead, Dr. Joyce Wamishwe. The topic we're going to discuss today is on digitization, health digitization. And I had explained earlier on the UHC. There were three acts that were enacted on 19th October. Yesterday, we had an overview discussion of the first one, which was the social health insurance. And today, we're going to have the discussion on Digital Health Act. But before that, I'm going to welcome Daktari. Daktari is a colleague of ours from Ministry of Health, but now she's stationed in the Digital Health Agency, which was enacted by the law. And she will explain to us the digitization journey in Kenya, the past and our future, how we see it. And then the CEO will come in and explain further on how we fit into the digital highway and what's the vision for the for the digital health agency. So, without much further ado, I will allow Dr. Joyce Wamishwe. Wamishwe, how are you?
I'm fine. Yeah, I'm fine.
Great to have you here. Karibu sana daktari. So take us away. I can see we have presentation today. Tafadhali daktari. The team, the audience is eager to hear what you have to say. Karibu.
So thank you, Dr. Amina, and thank you to the organizers for giving us a few, like 1.5 hours today to share about an exciting topic, digitization. And I'm sure a lot of us will be able to connect with what I'll be saying. I also would like to really appreciate that I'm doing this with our CEO of the latest saga under the Ministry of Health, that is Anthony Lenayara. We have a saga called the Digital Health Agency, and by the end of this, I hope you'll see how it works in what we're doing. So I'll be taking us through a few slides to appreciate the journey, where we've come from, and then what we're anticipating and our vision. And what I like to term this presentation is more of harnessing digital technology to optimize health. So that is the outline of my presentation. We'll dwell a lot on the journey, but we'll also get to see a use case. We'll use the HIV data to really appreciate what we are looking forward to seeing once we digitize. And then going forward, I'll talk a bit about what we want to do in the next few months, weeks, months, and perhaps 2 to 3 years. So we always like to start with this so that we appreciate why we are doing what we are doing. So we know we are implementing universal health coverage. This is for the nth time, and we hope that we are going to get it right this time. But what is more important is the various shifts or the various reforms that we are bringing in on board. So we are shifting from a curative, we are basically a predominantly curative health system. For a while, we've been like that. We want to shift back to preventive and promotive and prompt referral when required. Hence, we see a very strong component of community health. And then we have 4 pillars. And obviously, human resources for health is one of those. The other one is health products and technologies, just making sure that we have everything we need to make any diagnosis that we require, and then thereafter, the medication that we require. And then all this needs to be financed. Hence, yesterday we were able to be taken through the social health insurance, what it entails. And then today we are talking about the pillar health information. So under health information, we like to pride ourselves that for all these other pillars to work optimally, we do require real-time data or near real-time data so that we are able to make decisions. So health information is exactly that. And we also like to bring out the thing that we know that since we started seeing the first patient in this country, there has been health information. But what we are doing is health data transformation. And at this time and in this era, we are using technology to do that. So we only, I mean, I'll take you down a journey of how we got ourselves where we are. And it's always said the only time you should ever look back is to see how far you've come. So this is where we've come from. A point, and I know a lot of us can relate with this, a paper-based system. So initially there was data, but not being, managed in a certain manner. And then we got into a purely paper-based system, and a lot of us have worked in health facilities where files are like this. Sometimes the files could get lost or cannot be seen, or a file is inside another patient's file. And then we went to something more of a hybrid system where files are neatly arranged, but we also have a computer on the desk and a lot of retrospective data entry going on. So at this point, we could see some hiring of extra data clerks to input into the computer what the clinicians had, or rather the healthcare workers who managed patients had put in these files. And this picture was taken a few years back when we were doing a data quality assessment from a HIV program perspective. And then an electronic health record system started mainly maybe programmatically. And then we now know that there are facilities that have end-to-end hospital management information systems or health management information systems. So it's been a journey, and we've learned a lot. From a data perspective, given that I talked about what we are having is a health data transformation using technology. So this is a few years back. In 2020, we had to revise, for those who are working in the HIV program, we had to revise the blue card to the green card. And together with that, we had to bring in registers that, for example, we needed to move from 2 age bands. So before we were seeing less than 15 years and 15 and above. That is the data that we were summarizing and sending to. Then it was called DHIS. Today it's called KHIS. But along the way, we began to understand and appreciate that we needed to look at adolescents a bit more keenly. Hence, you now start seeing an attempt, an intentional attempt to have adolescent data being, summarized and also reported in KHIS. But what did this mean? That, you have to have male, female, male, female. So you can see we moved from possibly 4 reporting lines to all these reporting lines. And you can also appreciate that when you look at the less than 5 years, this is the data that we currently have. I mean, these are the number of children who had cholera at some point less than 5 years. But we would like to know, was it the under ones that had more, or was it the age between 2 to 5 years? You cannot tell that when you have aggregate data. And then there is a time we did a HMI assessment to see how many systems did we have, and this is what we found. I like to call this the Madhogodhanyo slide because it really tells us what was happening at that time. A facility could have, and even up till today, we know there are facilities that have, 3 EMRs, if you're seeing managing HIV patients, you probably have the Kenya EMR. Then if you're doing NCDs, you probably have SPICE. Then you have a billing something, and then maybe you have something else that's also collecting data. But all these systems were not speaking to each other. Each system was collecting, was giving an identifier to a patient. So a patient could have up to 3 identifiers, and they're still going to just one facility. Yet we know that we should be managing patients and not managing their diseases, actually. Then last year, we did a Kenya Health Facility Census, and what it showed is 1/3 of our facilities where the total facilities that we were able to assess was about 12,300. So a third of these have some form of electronic health information system. Many of them seem to be having an end-to-end. And we know a lot of these are private health facilities, but then also we know that program service specific are also quite heavy. And what we can say is when we look at this data, there is a story for each county. So there are counties like Mombasa County that have more private health facilities than public health facilities. We also know that digitization increases as we move towards level 6. So level 2 and level 3, which are the base of the primary health care, are least digitized. Then we have done a lot of policy work, and we like to look at this timeline to also savor in the moment of how far we've come from. And we just decided to start from the Constitution of Kenya. And along the way, you can see we've done quite a lot. I don't know, this just needs to disappear somewhere. So we can see right from 2010, for those of us who are around, we had some standards and guidelines for EMR. And around this time, I can recall, we actually said the country could use 4 EMRs. FunSoft, Kenya EMR. There was another one that was mainly being used in faith-based facilities. And along the way, we've come to appreciate that it is not that it is not defining like how many EMRs or what type of EMR should be used, but rather sticking to defining the standards and defining the guidelines to enable an EMR or a HMIS join the Health Information Exchange. I'll be speaking about that later. Then we also have this particular health sector unique identification framework, how to uniquely identify who we are managing. It looks like it's taken some time for us to have this framework. For quite a while, each facility was giving its own unique identification. But of course, if you move to another facility, they have to start the whole story again because they don't know what was happening in the other facility. We did attempt to do some unique identification like integration in the HIV program, but still that did not work. Then finally, we accepted that let us use what is in existence, and we are currently fronting the national ID as the unique identification for use in all this digitization work. Then we, of course, have the Digital Health Act that was assented to last year in October. And we do have draft digital health regulations. Those ones are yet to go through public participation. But we pride ourselves that even as people keep on saying that this is one act that is very technical, that once they understand the spirit behind the act, then they really appreciate what this whole legislation is trying to do. Okay. So just to talk a bit about the Digital Health Act, one of the things that it does is it establishes the Digital Health Agency, ASAGA. And the reason why this was established was because after a lot of push and back and forth, we had been writing this particular legislation since 2018. So at some point, we thought a committee would work. We thought that the Ministry of Health could deliver on all this vision that we are talking about in the Act. But at some point, we realized that for people to really trust, because the currency of trust is so important. One of the ways of ensuring trust is to ensure that people understand that their health data will be held in the utmost, it will be secure. So we need to hire people who are cybersecurity experts. And we know that in our current public service PSC cadres, there is no such person. So the only way to do those kind of things is to move away from the ministry and get to a place where we can be able to ensure that we have the right people doing the work that is required to ensure that health data is integrated, that we have an integrated, digitally integrated health ecosystem, and that data is secure and it is being used to obtain insights, that we have competencies that include even big data analytics. And then the next thing that this act introduces is the establishment and administration of the comprehensive integrated management system. This is not first envisioned here. It was envisioned in the Health Act 2017. And all what we did was complying with what the Health Act had described that needed to be done regarding this. I'll speak about this system in the next slide so that we can understand. Then health data governance is another key thing that this act introduces. It introduces key things such as recognition that health data is a national strategic asset. It introduces the words that such as who is the custodian of health data in this country. It's the Digital Health Agency. But of course, it also goes to complement what is in the Data Protection Act that really acknowledges that the owner of personally identifiable data is actually the data subject, meaning you and I. The biggest section in this act is the confidentiality, privacy, and security of data for obvious reasons. We realized Kenyans fear people knowing that what their health data entails compared to what their bank accounts have. And this is the one question that we keep on being asked: how secure is my health data? Who gets to see? Do I have any power deciding who sees my data and who doesn't? Then we have the digital health service delivery. This describes how digital health will be provided in this country. And in there, you see certain things regarding EMRs, telemedicine, and also describes how this is going to be done within, like if there's a foreign doctor who is using perhaps some telemedicine software, how we ensure that that person is a legit person. So there is mention of that they have to go through our regulator, KMPDC, those kind of things. Then, of course, responsible legislation, given that with digital health will come a lot of laptops, desktops, and all other manner of IT equipment. We have e-waste management. And then we acknowledge that digital health is going to be a key enabler for health tourism. And we also mentioned something about that. So that's just an overview of the Digital Health Act. Now, this is a slide that is titled Kenya Digital Health Superhighway, mainly to talk about the Health Information Exchange, which is this rectangle in the center. But if I was to retitle this slide, I would call it the Comprehensive and Integrated Health Information System. But because we want to zoom into the highway, because this is the other reform. For the longest time, through the whole cycle that I have shown you, we used to wonder, how do we connect one EMR to another? And we used to think we should be spending more effort connecting EMR to EMR. But obviously, with the previous slide, I showed you the Madhugodhanyo slide, and also the knowledge that we have over 4,000 kind of solutions, digital health solutions, including even mHealth apps, we cannot logically do that. So what is the next best way of doing it? We can decide as a country to go, the Rwanda way or the Indian way, and say we are going to have one system. So that also makes some sense, but then that stifles innovation. So the health information exchange is an innovation and is also a key reform, and we are very proud that we are one of the frontier countries that is raring to go to and demonstrate that using a HIE, we can actually be able to have a comprehensive integrated health information system. So obviously, it starts with an enabling environment. You need governance and regulation. I've talked a bit about that. Standards, compliance, we are continuously making sure we have that. We obviously need the national ICT infrastructure. We are working with MOICT on this to ensure that we have what is required from an ICT infrastructure point of view. And then the health information exchange, which has the interoperability layer. And of course, this is what we call the nerve center of a comprehensive and integrated health information system. So in there, we have things that enable us to communicate from system to system. So we are able now to identify whoever is being offered a service, our patients, our clients. So we have the Kenya Client Registry. And then we are also able to identify who's providing that service. Are they legit? Are they up to date with their licenses as per the regulators? That is the Kenya Health Worker Registry. We're able to know where they received the services. That is the Kenya Health Facility Registry. Last year we flagged off the community health promoters. So we also have a community health unit registry to just make sure that we know who is a CHP. If they fall out, then that update is done. Then we need a common language so that hypertension is the same across board. You know, we're not saying hypertension. Another system is terming it high blood pressure. Another one is writing it as HBP, and all manner of things that we usually have out there when we are putting our notes as healthcare workers. So we have the terminology service, which includes also the product catalog. Then we have what I like to call one patient file for every Kenyan. So yes, there will be a patient file in the point of care solution that you're seeing with at that facility. So if it is Mbagathi, you are seen using a point of care solution, your patient file is in there. But for continuity of care, say you've gone to Mombasa for a retreat or for holiday and you fall ill, then you're taken to Coast Coast General. They don't have to start asking you lots and lots of questions. They access your shared health record, and they're able to see certain things that are critical for continuity of care, like do you have any chronic diseases? If yes, which medication are you on? And all other, are you allergic to certain things? What's your blood group? All those things are in this. And then we have a whole service for e-claims, telemedicine, and even the logistics supply chain. We intend to be able to monitor medication once it lands in Kenya and all the way to when it is dispensed. All those things will be monitored here. Things like pharmacovigilance, things like forecasting and quantification will really help. The FNQs will really help our suppliers and even KEMSAs to know how much they need to order. So this is the nerve center. This is the health information exchange. It is the superhighway. The same way the government built the expressway, such things are built by government. If you start doing these kind of things, building highway, and you're basically just a vendor, you cannot be able to do that because it involves a lot of stakeholder involvement and understanding and consensus to have this kind of thing. So the highway now tells you to join this highway, this is what you need. Like we are able to tell you this is what you need. The same way to join the expressway, you need a car. It needs to be having a registration plate, for example. Now, around it are the things that will utilize the highway. So point of care solutions, these are the solutions that are at the facility. So think about the facility that you work in, the facility that you typically visit. When a doctor sees you using a computer, whatever that is enabling them to see you is what we call point of care solution. And of course, it has several modules. We also have the ICHIs that is being utilized by the CHPs. The digital kiosks, this will be something very common in the near future, and then other point of care systems such as like ambulance. Ambulance we will have a point of care system for that. Then these are the many government agencies that we have had to link up with for them to, because they are the true sources, sources of truth. For example, IPRS is a source of truth for client registry. Our regulators like MPDC, the Nothing Council, they are the source of truth for the Kenya Health Worker Registry. And then we also have the health insurance providers and the HPT suppliers. Then up here, we have the analytics. So we will have serious national health analytics and intelligence. And of course, we have our public health reporting. So is DHIS stroke KHIS dying? No, it will not. We will still have those, a lot of reporting happening through there. But of course, we have to move ourselves from the manual kind of thinking that a report has to be done every month. With technology, we can even have weekly reports. Then this is also a key reform. Empowering the patient is one of the key things that we want to do with digitization. So we have a patient portal called Afya Yangu, and you will be able to follow a lot of things, book appointments, know about your SHA contributions, even know about level, where has your pre-authorization request reached, those kind of things. So this is the comprehensive and integrated health information system that was envisioned in the Health Act 2017. We have just actualized it through the Digital Health Act, and this is a game changer. Now, just to talk a bit about SHA, because it's really related to what I've described, we have 3 channels for registration: the USSD channel, *147#. We also have where you can be assisted by an agent. We are looking at CHPs as one of those agents. Of course, the previously NHIF offices are also agents. And then we also have the web bit. So just to show you how it looks like. And this is how the USSD option looks like. You continue and you are able to reach up to the end. We are trying to make this really user-friendly. Bear with us because it's an iterative process. And I can tell you, for those who initially registered and the ones registering today, obviously the ones registering today are having a much better user experience, because we are listening and ensuring that we are incorporating a lot of the input that you're providing to improve the user experience. I wanted to show you the Afya Yangu, which you will see once you go through the sha.go.ke. So it looks like this, and through it, you're able to register also with the Social Health Authority. Yeah, that's how it looks like. So it's not a story, but it is actually there. Then why are we doing what we are doing? I've talked about this as I was presenting. We want data for decision making, and we want it as real time as possible. We also want data that enables us to continue giving you services, so health data portability. We want to harness the power of individual level health data, and I'll be demonstrating a bit of that. And of course, increase efficiency in health service delivery in everything we do, right even from the triage. Once we are able to look at even how long someone comes, how long someone stays in a facility, we are able to look at what can we tweak in our clinical flow, so that people don't have to stay a whole day in a health facility seeking services. So I just want to demonstrate a bit using the HIV testing data use case. So this is where we are at. So aggregate level health data, and this is where we want to go. So we are able to look at finer age disaggregations, which we cannot. If you can see the previous slide, we are only able to see 1 to 9. These are the number of people who were identified as positive. That is last year. But if you unpack this, and this now we are using data from the HIV EMR National Data Warehouse, we're able to see that a lot of those children in that particular age group were in the 0 to 2 years. But we are also able to see that at 10 to 14 years, we are still diagnosing children to be HIV, and perhaps they have lived all this if you assume that they all acquired HIV from mother to child transmission. Again, we want to look at how can we monitor whether guidelines are being utilized. So sometime back in the HIV program, we said same day start. So if we are doing the aggregate kind of reporting, we cannot be able to tell this, because again, this would mean going and adding columns in the register. But if we have individual level data, we are able to analyze it and manipulate it and be able to see what we want to see. I mean, the question that we want to answer. So here we can see a lot of our patients who are 0 to 19 years are starting, about 80% have same day start, but we can see that there's still quite a percentage that starts way after 30 days. So we then are able to do some interventions. This is mother to child transmission data, just to demonstrate that when we have rich individual level data, we are able to do risk factor analysis. And just from this particular table, you can be able to see that these are mother-baby pairs that we were following up. And we are able to see at different variables the MTCT rate, and you can see where a mother did not have any viral load during PMTCT, the MTCT rate is very high. Where a mother was diagnosed to be HIV after delivery, the MTCT rate is highest if you compare with if they are diagnosed before pregnancy. Just examples of showing when we have this kind of data that we can do something to improve the services that we provide in the health facility. So going forward, we acknowledge that, yes, we want to go very far. We dream of a digitally integrated health ecosystem. We dream of a level 2 health facility, seeing its patients using a tablet or a digital device and doing something about the data at that level. The private sector, we know a lot of private sector one-man kind of clinics are pretty happy seeing their files lined up against the wall, but we also want them to be able to quantify, for example, how many autistic children they have seen in the last couple of years. Is the trend increasing? And can we do something about it? Is there a risk factor that we can tweak? So we want to go far and go to, so we definitely have to go together. And we definitely never want to forget why we are doing this. It is more of a health data transformation. It is use of technology to optimize health service delivery. So we improve data quality, and what will that do? Once we analyze that data, we will improve quality of health services provided, and definitely we will input that into formulation of sound policies and innovation. Thank you very much. Over to you, Dr. Amina. Thank you.
Yeah, thank you. I love the thoughts you picked. If you want to go fast, go alone. If you want to go far, go together. I like it because I can imagine this process of getting this act has taken so many years, but it's about time, and we're very grateful for the work that you've done. I'll dive into the Q&A after Dr. Anthony gives his presentation. Sorry, I have a thing of calling people doctors, but please put in your question in the Q&A box. We'll try and address as much as possible. Anthony, as I'd explained earlier, is the current acting CEO for Digital Health Agency, and he's going to take us through the agency that he's spearheading and his vision, or rather the vision of DHA. Karibu, Anthony.
Thank you, Daktari. Can you hear me? Let's confirm, please.
Yes, yes.
Thank you, Daktari. Thank you, Dr. Amina. Thank you, Dr. Joyce. Actually, Dr. Joyce has covered most of really what is there in digitization, but I'll just go through again in some areas and not really to repeat, and also answer some questions that has been raised. I was following up as Dr. Wamishe is presenting. So I will go through and try to answer some of the questions. But normally once you talk after Dr. Wamishe, you really have very few words because she has covered everything. She has covered from the journey of where we came from, where healthcare was, what are we trying to do, where are we going, and how does the future look like. But for me specifically, I will cover the Digital Health Agency. What is the functions of the Digital Health Agency? She has already covered most of other areas. And what does the digitization program look like going forward? Not able to move. What's up? Better now, thank you. So again, the Digital Health Agency is from the Digital Health Act. I think Dr. Amishe has already highlighted. It's part of the 4 acts that were passed last year, 2013, by the president, and really to look at 2 key areas. One of them is to establish the agency that is to do all those things that Dr. Amishe had already highlighted, but also to establish a comprehensive integrated digital health information system. So these are the 2 key areas, but they have several functions that or mandate that the agency has been given to do by the law. One, of course, is to develop, operationalize, and maintain a comprehensive integrated health information system, or what exactly Dr. Amishe was talking about, health information exchange. And within that area, the mandate went deeper to actually explain that it establishes the registries that were within the health information exchange, but in consultation or in concurrence with the regulatory bodies. So for example, registries that are for health workers, we are not doing the regulatory work of regulating the health workers, but really to establish or to make those registries digital for use of both facilities and the whole health ecosystem. The third is about sharing of data to ensure really that we are able to share data across the whole health ecosystem, ensure that the records that are there for health records that are available are able to be shareable within different systems. But more specifically, and I saw a question coming up, is to ensure that that data is protected and all Kenyans are able to trust the use of the system because the data is protected by the authority. Data portability, I think we have talked so much about that. Analytics is another area that is looking around using all the system to be able to give analysis for planning, for usage as we move forward. Is another key area that the agency has been given functions on. Strengthening existing health information system. We have an area where we are coming in with the authorities supporting in standardization, because we realize that I know that Dr. Amishe was talking about, one of the problems is the systems themselves are not on the same standard. So the agency will also support in ensuring that the whole ecosystem of healthcare, they have been supported to upgrade their system, or they have been supported to ensure that their systems are standardized to be able to talk to one another. So it's going to promote that as well as help in support when it comes to that. Development of standard is another big area, of course, in conjunction with all the ecosystem. Develop standards that are used in providing digital health, or as well as providing digital systems within the healthcare area. Finally, resource mobilization and certification of health information solution. So these are the mandates, but if you want to break them down, mostly on the standardization, comprehensive integration, health information systems, looking at areas of data portability, as well as helping the whole country to be able to talk to one another. As the Dr. Amishe had indicated, the approach of Kenya is not really to have one system. It's to encourage innovation, but to be able to be on the same standard, to be on the same page for all of us to be able to talk to one another when we are talking about system for digitization, because digitization is really an enabler. And as Dr. Amisha had also indicated here, the shift that the country is moving now, digitization is just an enabler of that. And therefore, for each and every pillar of UHC, it's able to enable that pillar to work more efficiently, to be able to provide services to Kenyans more efficiently. So it's just an enabler of each and every part of that. After this, we looked around and said, how do we look like? For those of you in technology, we look at what is called an architecture. We actually identified we have a lot of systems within the health ecosystem, whether in facilities, some of them are for specific diseases. I've seen questions saying the Kenya EMR, is it able to integrate with this system, or another one called FKE, or another one developed by somebody else? How do we able to talk to one another? And we realize that we are all in very small corners. We are disintegrated, and therefore we need to find a way that we will speak to one another. And as Dr. Amisha had already also highlighted this picture, this is actually the roadmap. This is actually the plan of Kenya as a country to become a comprehensive integrated health information system. So what did you do here? We put an architecture, without going too much into details, that looks at 5 key areas. And we realize, why are we not talking to one another? The first reason why we're not talking to one another is the enabling environment. And in this enabling environment, we're talking about standards. We are talking about the act having an act now, Digital Health Act, that actually helps all of us to be on the same page, having several standards as we keep going forward, agreeing on those standards together, and being able then to implement systems that talk to one another. Because unlike human beings, systems talks on codes. So you need all of them to be on the same area. You need all of them to be technologically able to speak to one another. And that is one and the first pillar, that the agency will work together with the health ecosystem to ensure that we are able to implement this together. The second one that came as a big pillar that really needs us as we move forward is looking at the ICT infrastructure, looking at especially ensuring that if you are one facility have a system, another one doesn't have. In one region, some facilities have systems, some don't have. They are not able to talk to one another, or they have system, but there is no connectivity between one another. So we build another pillar that really looks at how do we ensure that we are all connected to one another, specifically for healthcare. And this pillar talks about data centers, how our data is stored, how assured our data is secure. We're building now what is called, the world is moving to cloud, but how do we ensure, because this is sensitive data, this is health data, to ensure that that data storage is protected, it is only accessible for use of health, for use for health, provision of health across the country. We're coming up with what is called sovereignty health cloud, which is really the area where our data will be stored. Storage will be stored in signals. There is no data that will be decrypted without the consent, without the subject, who is really either a patient or a client at that specific area, giving authorization. That is how we are moving in that direction as we move forward. Now, another part of that pillar is connectivity. So as the Ministry of ICT runs with the digital superhighway and creative economy, ensuring every country is connected, priority number 1 has been given to health facilities, all health facilities, ensuring they are connected, ensuring they have power, government having programs to ensure that they support the whole ecosystem, to ensure this connectivity is provided, both for power, both for internet, so that we're able to speak to one another. Then end user devices, Dr. Amisha again had highlighted this. How do we ensure that everybody have tablets, everybody have laptops, everybody is able to use devices to provide some of this solution? That therefore is another big pillar that the agency is working together with the Ministry of Health to ensure then that we move together in that direction, supporting the private sector, faith-based organization, as well as supporting government facilities that really have nothing when it comes to ICT infrastructure. The middle, I think Dr. Amisha had highlighted it very clearly. You will see the 6 registries, but these 6 registries, the client registry, for example, I've seen a question on identification. We are moving in that we identify patients or we identify clients according to how the government have registered them. So we are under this ecosystem also, we are giving the provision, just like it is in the financial sector, for you to be able to use your identity card, to be able to use your birth certificate, for you to be able to use the normal approved identification. And even don't store your data too much on those on many systems, but they are able to be used specifically for the time of treatment. And the whole idea of this exchange is then you don't have to store data across so many areas. Let the point of care services be able to consume these registries. Let them be able to utilize these registries whenever they need to. In terms of health workers and facilities, we are not coming with regulatory of that. But what we are doing is we are linking in and also digitizing our regulatory bodies so that for health workers registries, for example, KMPDC and other regulators, we are then able to know who is registered, and therefore we are also able to know to identify them. But we are not creating another layer of us registering people. No, we are just linking for any point of care system to be able to read it from there and consume it for any services that they are able to consume. Facilities the same. No registry, but link them to the regulators and having one point whereby any point of care service is able to link in and therefore is able also to provide services in another area. Terminology service, I think Dr. Amisha has highlighted. Shared health record, she has also highlighted properly. This becomes our single point of truth. And this helps us in able to have portability of data, because the same way I am identified at facility A is the same way I'm identified at facility B. The same way my records are stored in form of signals and are encrypted or decrypted only upon my consent at facility B. When I give authorization at facility X and the doctor is authorized to provide that service, then he's able to read my historical data. And this is the whole essence of health information exchange. Outside that, we also have the claim management system, and that we are also supporting all the claims within the private sector and the public sector, specifically now solutions to come up with social health authority claims, see where there are challenges and able to support that. I think I'll not go to details that has already been highlighted, but that is the vision. But even in future, the claims for private sector as well as the public sector, how do they talk one another? How do they use big data? How do we use AI to support one another to provide these services more efficient? Telemedicine, not really having one platform, but again, finding standards and providing an exchange whereby several telemedicine platforms that have been trusted, that are able that have been certified by the agency, and are able therefore to read within the exchange. Kenyans can actually be told that these platforms are able to be can be used and are able then to be used properly. So we are not really saying that government will have one telemedicine, for example, platform for everything. No, we want to encourage a lot of innovation, but encourage innovation in terms of standardizing that. Logistic and supply chain management is another area. How do we manage all our logistics? How do you have visibility when it comes to getting logistics? How do you know that this drug is required, this one have shortage, and all that within as a country? And again, for us, we are not saying that we'll have one system that everybody must have in that area, but we'll have a super highway where you plug in, where you integrate, and therefore be able to provide data that will support the logistic areas. The other parts I think has been discussed. Portal that is a Fayango patient portal where you're able to track your record, you're able to see your claim, you're able to see your whole process as you move forward. Analytics, Dr. Amisha, I think I've talked about. Point of care of services, I don't want to insist so much. It's not really our area to say one of them must be used, no. But ensuring that they're of the same standard, ensuring that therefore they're able to read within this exchange so that they can speak to one another. And after that, allowing innovation, allowing people to bring in point of care services. For government specifically, for example, I know there's been a question about AFEKI, Kenya EMR, and now the one that we have is called Tibabu. This was one of the things we have done, for example, is for Kenya EMR, we have upgraded it to be the level that is required, to be of the standard that is required, and actually already integrated to the exchange to be able to read it in the exchange. But we also need that solution, for example, not only to serve HIV or a specific area, but to serve the whole facility, become a hospital management system that have an EMR, that have as well as ERP for provision of that service. Integration of government services, we will also integrate them. So this is how the future look like, and this is the plan that the agency is implementing to look at that area. If again I come to these slides, it's just the same. Having the health information exchange and having point of care services leading to it, and also being able to pull in data from logistic, from ambulance systems, from telemedicine system, from insurance system within the HIE, and also encourage a lot of interconnectivity and a lot of people being able to share data to provide that services. So how will it look like in terms of facilities? So for facilities, specifically for public, we are giving them access to these client registries, but also for private sector, we're giving them access to all these registries. I have seen a question about the APIs. The APIs are already ready. We have a portal called Afia Link. You will be seeing a notice, a public notice by the agency, the course of next week, to say for you as a developer, please register through the Afia Link. You should be able to get APIs there and start the integration journey. But as you do that integration journey, we will be able to support you. So they will be provided with some of those systems. Also for public facilities, we will provide some connectivity. Where there are no connectivity, we'll provide internet. Where there are no internet, we'll provide bundles where bundles are required along that area. For health workers, the regulators that have a challenge with system to come with licensing, we will also support that. A lot of education will be coming in. You will be seeing us doing a lot of training to bring everybody on board and keep supporting one another along that area. For those that are in public facilities, they will be provided with gadgets. For example, areas where there are no gadgets, you actually support the whole of that digitization area. So a lot of good things are coming as we move forward, and we'll be reaching out to you to do training. We'll be reaching out to you to ensure that then we are on the same page. Pharmaceutical management information system, or what we are calling national logistic management system, has track and trace, for example, has how distribution is done, how safety is being checked of drugs, and all of that area, pharmacy management. But we're not saying that you'll have one system that everybody is using. We're building a super highway. You can see importers will be integrating in, wholesalers will be integrating in, providers will be integrating in, pharmacies will be integrating in, so that then we are able to give better analytics for provision of drugs within the whole of that ecosystem. Now, for public facilities that doesn't have EMRs and the rest, the government is upgrading that and ensuring that every public facility has an EMR, has an ERP, that then is able to support the provision of digital health within the whole digital ecosystem. So those are some of just high-level functionalities. Now, connectivity, how are we doing connectivity? I think this is important. We're using the PCN model. I'm sure you have engaged on how the PCN looks like, having a hub, having a spoke, and bringing in both public, bringing in private sector, faith-based, and having that PCN interconnected to be able to be like a community, to be able to share data. And we did, for example, a sample that we did in Kapkatet. This rollout will start going on, and you will see now as a lot rolling out and having discussions on this. That is the model we want to have, having a level 4 and integrated how the PCNs are, but that PCNs outside having governance and other areas, also having systems in place to be able to share data, to be able to support one another as a community. So I think that is it from me. Unless questions now to clarify more, but that is how the vision looked like. Most of this had already been covered by Dr. Wamishe. I didn't want to repeat a lot, but I hope we have answered some of the questions that have been raised, but we will be open to answer that. I saw a question on data. I think this is very key. So all our systems have what is called data protection impact assessment. That is, first we must get clearance through the ODPC. But again, outside that, we have to protect it more to ensure that a Kenyan trusts the systems and to be able to provide systems going forward without a lot of challenges, not knowing who has your data, how they are storing, and who provides your data within that area. Finally, after the act was passed, we will be doing the regulation soon, and you will see a lot of public participation to do regulation of digital health agency, and we need a lot of support from you so that we work together, come up with regulations that really support us to have that good vision that Dr. Wabishe had projected for us. Otherwise,
Mm.
mine is thank you so much. And back to you, Dr.
Yeah, thank you. Naona lakini bado uko 2023 on a very
Oh,
light note.
my
Nani, kindly put in the digital highway. I think it's a very informative slide that we can, if that's okay. But thank you very much. You've really summarized and make things very, very clear. And it builds on a lot of the discussions that we've been having. So before I jump into the Q&A, perhaps maybe you can start with the first question from me. What problem is DHA solving for us? I know you've mentioned it, but just in a nutshell. CEO?
Sorry. Thank you, Daktari. The problem DHA is solving for us is one, standardizing most of these systems. So ensuring then, therefore, that we are able to have systems that speaks to one another. The second thing is doing is encouraging portability. So helping in that area of regulation, in that area of really working together to come up with standards that ensure that therefore our system are portable. We are able then to talk to one another. The third thing that DHA is bringing to us is this comprehensive, what we're calling the health information exchange, having shared services, I can call it in a simple term, shared services that we all need for us to be able to have data portability, for us to be able to ensure our data is secure. That is the other thing that DHA is really bringing to us. But outside that is to support digitization within the whole this ecosystem, to allow us then to be able to use digitization as an enabler of provision of healthcare services, but use digitization in a way that bring a lot of public trust to use of digital system in provision of services. And finally, to help you get data for analysis, get data for decision making is another area that Digital Health Agency really is bringing to the whole ecosystem. Thank you.
Thank you. I'll direct this to Dr. Wamwishwe. Kenya has a lot of policies which are very beautiful. What are we doing to safeguard and which bottlenecks are we foreseeing, and how are we planning to mitigate it? And perhaps Anthony can answer further, especially about support system, if it will be available in case it's needed, if we have plans to set up a 24-hour support system.
Yeah, so I've seen quite a number of questions talking about how exactly what you've brought out, and I think I've responded to one or two by saying we should be, first of all, very proud as Kenya that we are brave enough to want to now implement this. We have learned a lot from the early adopters of digital health, the private sector that went ahead of the public health system, the programs like HIV and TB. And through those lessons, a lot of things that we've been tackling over time, we have figured that out. So now we want to expand what has been happening in the private sector, what has been happening from a programmatic point of view for the whole country, for the things that Anthony has talked about. So for sure, we seemingly are very confident about where we are going. We know it's not going to be easy. There's still quite a lot of learning. So we are starting in phases, identifying the low-lying fruits, like facilities that are already having end-to-end HMISs. Are they able to join the health information exchange? And I can see some people are even asking what standards are we using for the interoperability layer. And then we have a full risk matrix that we've identified. These are the possible risks. Of course, things like some remote facilities not having internet connectivity. We are currently doing an assessment to really identify which are these facilities. We did an initial assessment from the facility census we did last year, and we are now having a more intense assessment. And we have a plan for even those type of facilities. Of course, again, this kind of implementation is not MOH only. It is multi-sector, multi-level kind of implementation. We are also looking at change management of our human resources, our healthcare workers. But we are encouraged when we speak to counties that are already implementing this, and they tell us, yes, the healthcare workers, this is what they have been waiting for, but this is how you go about training them for them to quickly adopt and adapt to digital health for service delivery. So the other risk is possibly financing. So we are currently even working on a digital health strategy for the country to identify innovative ways for sustainable financing. And of course, one of those is tap into the private sector. We also want to promote a lot of innovation amongst our young people so that we can have digital health solutions that are more practical and affordable for our kind of setup. So those are just some of the things that we have out there. But one of the things I would request is we are not doing this from scratch. We are doing this from many years of learning. For us to even come up with that unique identifier framework, that was not work that we did in 1 year. For about 6-7 years, we had been trying to figure out how will we be uniquely identifying patients. It looks easy when I say we have come back to the national ID, but we had all sorts of ways of doing this. So we have to have some faith and trust in this. It's a good reform. It's one of the positive, progressive things for the health sector. Thank you.
Yeah, Anthony, maybe you can touch on the 24-hour support. Do you envision that we will be able to have that, especially in the initial stages, considering all the challenges that will come up with the teething issues?
Yeah, thank you so much, Daktari. Yes, just to confirm, we will have a 24-hour support in 3 key areas. One, we will have a call center where really we do the first line supports. We have a network operation center, which will be 24 hours within the program as well, that will be supporting in any technical issues. We also have a security operation center, what is called a SOC, for any challenges, any areas to do with cybersecurity, be able to mitigate, be able to identify. In terms of actually cybersecurity, we're implementing what is called zero trust. One, all the devices that we are using for healthcare will be whitelisted to be specifically used for the healthcare, the one within the facility, to ensure them that there's no data that is being at that specific time leaked out. 2, a transmission. All transmission is done through signals, so it's moved in form of light. All the data is encrypted. It's only decrypted once the subject gives what you're calling consent or authorization. And this, we're using different types of technology to ensure, therefore, that is provided. But out of that, in terms of support, we have even the Security Operations Center that at any specific time, when you have such a challenge, we're able to mitigate early, because this is healthcare data and we really want to protect it 24 hours. In terms of support of the integration and all these areas, we'll have a call center and we'll have a network operations center as well to support the whole ecosystem as we move forward. As Dr. Amisha again indicated, this is a journey. We are going to work together. Any improvements that needs to be done, we will be doing it together with the team and finding the best practices or best solutions therefore that is able to provide that going forward. But to confirm to you again, yes, we have a 24-hour support for the same thing.
Thank you. And I'm sure the audience would perhaps like to know how to reach into the 24-hour service, which will be shared, I guess, within the platforms if it's not already done. But for just us to understand holistically, you mentioned something called whitelisting. What does that mean?
So whitelisting, for example, in a layman's, allowing most of your systems or key system over the internet, over an open public network, means therefore that people can use technology to find a way to get to your systems. So what we do by whitelisting is for specific devices that are used for healthcare, for example, we only allow specific what you call URLs or specific portals or platforms for healthcare to be able to access. You cannot access other public services, for example, like maybe YouTube, Facebook, and these other public ones where we are not able to guarantee security at that specific area. So, for example, once we give a device that is used for healthcare for a specific health worker, that device is only used for provision of healthcare services. Okay, and also in case a device gets lost, for example, from the central point, we are able to clean the whole of that device and no data will be able to be accessed. So that is what it means, but it's more detailed in technology. When we have a technology discussions, then we can have more details on that. But that really, it is what it means by saying whitelisting and not allowing any other service to run on that device that can cause vulnerability for our system and as well as our data, as much as the data is encrypted and only stored and transmitted in form of signals.
Okay, I believe that's quite clear, and it also kind of answer one of the questions that was asked about, but you can clarify because you had explained it in your presentation on how will the ministry be giving hardware support, and maybe you can shed light on that.
Hardware, sorry?
Sorry, the question was for you.
Okay,
Go
thank
on.
you. This is the hardware support for facilities.
Yes, yes. Will there be support, especially in the public health sector, for it? Have we budgeted for it, and is there support?
Yeah, so for public sector facilities, we are providing the hardware. That means we're providing all storage services. We are also providing devices. That means every device that is being used for healthcare, for the public sector to provide healthcare, gadgets, these are tablets, these are computers, they will be provided for under the program and already catered under the program. We'll also be providing maintenance services. We will be providing connectivity services to ensure at no specific time any public facility will not be able to use digitization for provision of services because of lack of hardware. Now, this program is running out and you will it's rolling out now, and you will be able to see as we move to the counties. We have just started. You will start seeing as we move to the counties, supplying this county by county. Now, as we are also doing digitization, and I think this needs to be very clear, we are not just doing a plan within the agency or within the ministry and roll out ourselves. No, we have a very clear structure that we use for training. That means involving everybody. We have a very clear structure of how to digitize a county by county by co-creating digitization plans and be able to bring in everybody on board as we provide these services going forward. So it's a 2-year rollout program, but it has just started. Key priority now is really to ensure everybody is able to claim by 1st of October, be able to have claim services by 1st of October as we move and digitize each and every facility going forward, which really will take time. We need to be together. We need to co-create it together. So for the public sector, I will be provided.
Thank you. I'll direct this question to Dr. Mishwe. 1st of October is slowly coming on, and hospitals, FBOs from the platform are a bit concerned in terms of especially patients on dialysis who have not uploaded, registered themselves, and perhaps there's some issues going on. What are the mitigating factors for them to be able to um, still get the service from SHA or SHIF and be able to, how are we planning to mitigate these claims? Over to you.
So thanks, Dr. for that. So what I know is under SHA, they do have a support desk, and Anthony can speak more on this, that should be able to facilitate those who are having issues with this, with the registration process, to call in and say, can I be helped? But the other thing we are doing is, as I mentioned, there is what we call the agent assisted registration. And I did define some of the agents. So the community health promoters, I acknowledge that we should have had them quite ready for this registration process. But we also say that sometimes some of these things, we are doing them in a phased manner. So in terms of training the CHPs to do assisted SHA registration, that is now something that we are doing. So that should also sort out the person who has registered using USSD and then can no longer go to like the SHA website because they don't have an Android phone. So they are able to, if they're not meeting up with their CHP, then the SHA agents, previously NHIF offices, are also going through some intensive training so that they are there. They are ready. I know branding of these SHA offices is also something that is in the pipeline. So we should be able to see a lot of efforts towards facilitating people to be registered. But for now, for those type of patients, there is a support desk at SHA office. Maybe Anthony can just speak to that a little bit because it's important. Thank you.
Yes, Anthony?
Yeah, Daktari, yes, that is indeed true. We'll be providing the number for the SHA call center to support you in any challenges that you are facing during registration and even at the time of claim. So I will be typing in that number to the chat group. If you have any challenge, just call the call center. They should be able to support.
Thank you. Thank you for that. There's some concerns regarding the utilization of the USSD. Some people from the audience have said that it's a bit hard using the USSD, especially if you're from the rural area. I love how, Dr. Omishwe, you brought in the element of CHPs and how they play a key role in actually assisting and enabling us to be able to register and assist the common Mwananchi to be able to do this. But now for the USSD, if you want to upload your spouse or your dependent, it takes you to SHA, and you have like Mulika Mwizi, I think that's what they call it. Yeah, Mulika Mwizi. Um, how is that a system error, or it's just an error that one person has found out? So, Anthony, kindly address that.
Daktari, sorry, I was typing the number. I didn't get the issue with the USSD. If you don't mind, maybe you can repeat, please.
Yeah, so someone is saying if they have like a Mulika Mwizi,
Yes.
they use the USSD and they want to register, and it's not taking they can't register their spouse or their dependent. It takes them to the website. I
Yes.
personally haven't tried this out, so I don't know if it's a system issue or if it's something that you can shed light to how you go about it, such that if you have a Mulika Mwizi, you can have an end-to-end support for registration, even up to dependent level.
Thank you
Over
so
to you.
much. Thank you. Thank you so much. I think this is a very good question that we have been receiving. The USSD is indeed not able to capture some of your details, especially adding dependents. And even if, for example, you are not employed, you have to go and do what you are calling means testing, is not able to do that. And this really is because of limitation of the USSD technology. So USSD technology, normally for those in technology, has a limitation in terms of time, how long it can be. It also has a limitation in terms of the wording, putting names, long names, and the rest. And that is really the limitation. So that's why you see we send you a link and say to go and add your dependents, please go to a web portal, afyayangu.go.ke or sha.go.ke, and complete the other part that you have not completed in. Now, assuming you don't have a smartphone and you are not able to access internet, we have given 3 options. One option is your CHP, who is in your village, should be able to support you to complete that registration. If you are not able to get your CHP, a Huduma center that is nearby should be able to support you to complete that registration using the assisted module. If you are not able to get to your Huduma center, SHA offices, these are former NHIF offices, should be able or is able to support you to complete that registration. Now, assuming you are not able to access all the 3 and you find yourself in the facility, we are also now providing this capability within the facilities so that when you visit a facility, you are not registered or you have registered, but you have not completed, either have not added a dependent or completed some other part of registration that has limitation when it comes to USSD, the facilities should be able to support you. So those are the 4 options that we have provided. Apologies, because this is a technology limitation issues. The USSD technology can only support a small part of this registration, and that is the challenge we have been facing, but we have provided 4 other options to assist any Kenyan who doesn't have a smartphone or is not able to get to a web portal to be able to complete his registration. Now, again, you might have within a family, maybe a smart kid that has a smartphone, that person can actually register you. They can actually register the whole family. So assume Anthony's family, for example, or all other people don't have a smartphone and maybe only one has, they are able to support you to complete that part of registration. And those are the options that we have given going forward due to the limitation of technology when it comes to USSD.
Thank you. Thank you. Thank you for that. I love the way you've optimized the utilization of the existing infrastructure. We are using the CHP Huduma Center and the former NHIF offices, which will be rebranded itself. And also the facilities. I believe that's insightful information, and you've shed light to why the limitation of the USSD is a bit hard. Back to remote areas, in terms of internet connectivity, there's a challenge in terms of the last mile. How is the ministry, or rather, how is DHA planning to approach this challenge? Anthony.
Thank you, Daktari. Indeed, another big challenge we have in this digitization is connectivity, availability of internet. across the country. Indeed, yes, there are some facilities that doesn't have internet connectivity. So we have done several things to support this. The first, what the ministry has done is providing for options of what we are calling mobile network. So anywhere you have a Safaricom network, anywhere you have a Airtel network, anywhere you have a telecom network, you should be able to get these services, especially for the public facilities who are in very remote areas, which we are providing devices. They should be able to connect to the internet. They are being given bundles, and they are therefore able to provide services using those bundles. But we have also realized that there is some areas that actually has nothing. So you don't have internet, there's no Safaricom there, there's no Airtel there, there's no Telcom there, or even Jamii or any other provider in that case. And in this area, we have given two options. One, we have requested and the telecommunication providers are optimizing their network to be able to increase the reach. There are 4% that really has nothing. And that we are giving option of bringing in technologies that are able to provide internet connectivity in the short run. For example, what you hear nowadays, people calling low orbit satellites, or famously called Starlink and the rest, to support facility in the short run. But what has the government done again? They have prioritized healthcare or facilities connectivity in all government programs. The digital superhighway that is ongoing within the Ministry of ICT are taking facility or health connectivity as top priority to do two things. As they connect to power, they also connect to the internet. But we know that will come after a period of time. So that's why we have given this short, two other short options. But worst case scenario, in case we have nothing or the connectivity is very slow, we are creating an offline module whereby you can actually undertake a service and be able to submit it once you have connectivity. These are the options that we are putting in place as we fast track other government programs to ensure that every facility in Kenya has some form of connectivity and has some form of power. Now, power is another challenge that is really big for us. And what we are doing is the devices that's being distributed for the public sector, for example. The provider, one of them is charging those devices, but also giving them backup batteries that will help them in providing services. So they charge for them, they give them backup batteries, and they keep charging for them. Those are short-term measures we are putting in place, but the long-term measure is the government, two programs of government, one on ICT connectivity across the country, putting first priority to be health facilities, and second, power, which is also putting facilities, health facilities as top priority. We have already submitted this to the relevant ministry. They have prioritized that, and they will be rolling out programs to ensure that we have connectivity within a period of time to sort out some of these problems, even as we give a short-term intervention. Thank you.
Thank you. Thank you for that. So many questions, so little time, but there's one burning one because it will answer a lot of questions that many people have. And I'll direct it to Dr. Joyce. Will hospital facilities now, especially private sectors that have their own systems, will they be rendered useless? Over to you.
Okay, so I think I mentioned this, and thank you for that question. It's something that keeps on coming up. So as I said, we do not want to stifle innovation. So that is not the way we are going. We also don't want, we are not working in the spirit of start afresh. We are working more in terms of ensuring that people understand to join the highway, your system needs to meet the following criteria. And one of the roles of the Digital Health Agency is to go through a certification process for the various digital health solutions that are to be implemented in Kenya based on, certain criteria, and say this is what is usable in this country because it can it can be able to connect to the HIE. And where it can't, then the DHA works together with that particular, is it vendor, if I may use that word, to try and see how that will be done. But more so, for the facilities already that are using a system, already there is health data in there. Our eyes are there to try and see how we can work together with those particular systems to upgrade them or do something so that that system can be able to join the highway. And where now it's totally not possible, then we also have solutions that we have dubbed as MOH, available solutions where we can move that data into these solutions. But the spirit is not to stifle innovation and definitely not starting afresh. Yeah. So one of the things is like where a facility probably has been using Kenya EMR for HIV program. What we have told the partner concerned is expand the Kenya EMR so that it is now facility wide. Yeah, for example. Thank you.
Yeah, thank you. And speaking of partners, yeah, my last question. You mentioned the Mother Gavanio. In fact, it's a vibe in terms of our understanding of our digital infrastructure at the moment. How are we planning to have interoperability with the partners? I love the example you just gave of Kenya AMR. How about the other partners? How are we planning to streamline so that we have interoperability to avoid the mother news?
Yeah. So I think the one thing I would want us to leave this webinar with is where we have gotten to is because of the close collaboration with our partners, the digital health stakeholder team. They are the ones who enabled us, move a lot of these documents that you can see. They are the ones who are willing to share a lot of their lessons learned. And we've been able to even figure out a lot of things regarding this comprehensive integrated health information system. Now, the second thing that is important is we have no intention whatsoever of trying to connect Kenya EMR to Afya KE, like link to link, but the connection will happen through the health information exchange. So I think that is what that hard word you're talking about, interoperability. I spent a couple of years trying to say it for a while because that was the thinking before. How do we move Kenya EMR to connect to IQ Care, to connect to whatever other system that was there at that time? But the reform right now is we are all connecting and speaking to each other as systems through the highway. So I get in as Kenya EMR, I get into the client registry, identify who I'm seeing, where they are being seen. And then once I'm done, that clinical record is updated in the shared health record. When the patient goes to Mombasa for a retreat and meets a system like Afya KE or whatever other system that's being used, they get in to and access the record, of course, upon consent from the patient, and are able to see. So the linkage is through, the interoperability is through this highway. The same way you move
Thank
with a
you.
passport from Nairobi to Mlolongo, but you can come out at South B and then come back.
Thank you. Thank you. That was really intentional because it needed to come out very clearly how every player is going to play here. And I love your response. The spirit is not to change things, but make them work together and be this hard word, interoperable. I think it will be the statement for 2024. And so with that, Dr. What is your parting shot for this webinar?
As you know, I am very passionate about utilization of data for insights for decision making. And that's where my eyes are on for all this time. So it's exciting to be around in the health sector at this time, where there's possibility of even improving that data and transforming it to a level where we will move even towards, prescriptive, predictive analysis to enable individual level, kind of care. So this is something very progressive. It's a journey. I have seen some people saying we are sounding Zakayo-ish. No, we truly do have a plan. It may not be the best plan 100%, but it's a plan definitely built on lessons learned. And we are confident that we are moving in the right direction, and we look forward to seeing a lot of the vision that we have been waiting for many years. We look forward to seeing it actualizing during our generation. Thank you.
Thank you, Dr. And it's an honor to have you on that journey. CEO, what's your parting shot?
Thank you so much, Daktari. Mine, I think, is to appreciate all the participants in today's engagement. Again, comprehensive integrated health information system is not an event. It is a long journey. It's a big dream. Actually, those are the questions I keep getting every time we present this. People say, yes, it is a big dream, but I think it is a big dream for Kenya that Kenya can achieve. Kenya is known for embracing technology. Kenya is known for bringing innovation. Kenya is known for really doing magical things. And therefore, I think this is a journey. We can't do it together. We can't do it alone as Digital Health Agency. Neither can we do it alone as Ministry of Health, but we can do it together. It's a journey that we want to walk with you. It's a journey that we have started with that bold one step. We request that you hold our hand as we do it together. We will keep improving. We are not going to say it's going to be easy. Anything good is going to be hard, but we are determined to ensure that this journey, this dream of a Kenyan within our lifetime will be realized, and we will only be able to do this together with you. So mine is also to thank you so much. Thank you, the organizer. Thank you, Dr. Amina, for giving us an engagement to be able to engage with this team. This should not be the last engagement. We are hoping to come again every day until we together work to achieve this dream. It is also not the end of thinking. We don't have monopoly of ideas. So we'll be knocking at your doors. We will be together as we make this even better and make Kenya shine, because at the end of it, this is to serve us. This is to serve each and every one of us who at one point in our life, we are a client in a facility, we need health services, and this is healthcare, and we want to work together with you. Thank you so much, and have a good evening. Thank you.
Sorry, I think I had a network issue. But thank you so much for taking your time to share with us your insights. And tomorrow, we will have a discussion on the PCN. Anthony kind of touched up on it in terms of what is the PCN, but Dr. Salim and Maureen will be able to give us a better insight on what the primary healthcare agenda is about. Thank you. And unfortunately, we were unable to answer all the questions. There were some that were extremely technical. And this session will be uploaded on YouTube, hopefully within the week. And you'll be able to see it on the KNH YouTube channel. So without much to add, I hope you have been able to understand the digital health journey. And I'll see you tomorrow. Thank you. Have a good night. Good night. Thank you, Anthony. Thank you, Joyce.
Good night. Thank you, Dr.
Thank you, and thank you all.